Welcome and good morning to PACT's digital health program on technology and behavioral health. We are pleased and thankful for the sponsorship of Independence Blue Cross and Capgemini and Invent for this morning's program. Our format this morning is going to be an overview of the topic, followed by lightning talks covering a couple of areas, and then a panel discussion. We are thankful to be joined this morning by several experts in their fields, including Dr. Ginny Kallega from Independence Blue Cross, Dr. Varun Chaudhry from Magellan Health, Dr. Cecilia Livesey from the University of Pennsylvania, and Matt Michelet, the head of clinical operations for NeuroFlow. Just to review the etiquette for the webinar, again, attendees are on mute. Please use the Q&A window to ask any panelist questions. We will be monitoring questions throughout. You also can use the chat window to comment or say hello to fellow attendees or panelists. Before we kick off, let me start and just say it is with heavy heart that we present this program this morning in light of all that's going on across our nation. We thought long and hard about canceling this, and we remain in unison with others against racism and violence and hatred. And we'll be doing our part in communicating our part. In light of the importance of behavioral health for all of us, we thought it was important to continue with this program. And we're going to touch upon in this session some of the key points that are important here, including access, because there's not equality in access to healthcare and especially to behavioral health. So we welcome you, we thank you for your participation. And I now turn it over to Dr. Ginny Kallega, who is the Vice President of Medical Affairs for Independence Blue Cross.
Thank you, Dean, and good morning to everyone. Hopefully you can see my screen at this point. So I want to welcome you to what I think is going to be a very interesting and fascinating discussion. And I wanted to start off with some sobering statistics. So as Dean said, we have issues around mental health. Nearly 1 in 5 US adults experience mental health issues, and those serious mental health issues are concomitant or run in parallel with chronic diseases. And we also know that people with chronic medical conditions such as cancer, heart disease, have concomitant mental health issues such as depression and anxiety. But it's not just an issue around adults, it's also an issue around younger people, teenagers and millennials. And when we look to see issues around millennials, the Blue Cross Blue Shield Association had done a report in April of 2019 around millennial healthcare. And as you can see, the top 10 disease states in millennials include 6 that are behavioral health or mental health issues. And when you look at the far right column, that's the incidence in southeastern Pennsylvania compared to the national statistics from the Blue Cross Blue Shield Association database. So very sobering that 6 of 10 conditions in millennial behavioral health, but the conditions are even more prevalent in southeastern Pennsylvania. And as Dean said, there are issues around access as well as quality in mental health. They're a leading driver of healthcare cost, and the traditional delivery models are not always evidence-based, and the outcomes are not always easily obtainable. And so that's why Independence has partnered with Penn and Dr. Livesey, who I think is going to talk about the program that we had launched together about a year and a half ago, where on the collaborative care model, based off the University of Washington model, there is an embedding of behavioral health social workers in a primary care practice. So as primary care providers are treating patients, they're also, when a patient is willing to discuss their mental health issues, able to deliver that care within the walls of the primary care provider. We've also, as an outgrowth of our millennial health campaign, also partnered with the city on a campaign that just launched last month with respect to the issues that people are suffering, the stress, the anxiety within the COVID pandemic, and that's called Let's Be Mindful Together. This campaign is focused on community partners. It's really about raising awareness of the importance of talking about mental health issues, the importance of seeking care for those mental health, and that your mental health is tied to your physical health and your well-being. And so it's designed to reduce stigma and for the community that we live in to promote free mental health resources, as well as empower the community to help support each other through this. Independence has not only been focused on mental health issues, but we have been a national leader on the opioid crisis and opioid use disorder. So we've partnered with providers to improve prescribing habits, as well as, where appropriate, limiting new starts to a 5-day supply limit, excluding patients with cancer or chronic conditions like sickle cell. We've supported members, trying to educate members as well as engage members through case management to have them engage in treatment options. And then through community collaborations, we've increased access to naloxone by providing that to frontline healthcare workers, as well as having $0 cost sharing with them. And what we've seen in our statistics over the last couple of years is a 45% reduction in opioid users and a 35% decrease in prescribing. And we not only work through our insurance arm, we also work through our foundation. And the Blue Cross, the Independence Blue Cross Foundation has been partnering in the community for many years now, but especially around the opioid crisis. We have a warm handoff program where we've been working with emergency providers in Bucks County, so that if someone is revived from an overdose, how do we get them into care? How do we warm hand them off from their resuscitation to their treatment? And the Someone You Know campaign, if you've not gone to that website, I strongly encourage you to do that, really has focused on reducing stigma of people who are in recovery. Because it really could be someone you know, could be the person sitting beside you, could be someone in your family. So I wanted to just quickly share a number of things that we are doing here in our community. And now I will turn it over to Dr. Varun Chaudhary, who is the National Behavioral Health Chief Medical Officer for Magellan Health. Thank you.
Thank you, Jenny. Let me pull up my screen. Today, I'll be sharing with you our digital virtual care solution tools. And just a little bit about me. I'm a board-certified forensic psychiatrist and have been in managed care for about 7 years now. And most of it has been spent with Magellan. And I'm currently Magellan's National Behavioral Health CMO. So slide 1, this is to tell you a little bit about our company. Magellan has specialized in behavioral health for over 40 years, and we're committed to connecting behavioral health with physical health, pharmacy, and social needs with evidence-based clinical and community support programs to ensure healthcare services are coordinated and value-based. We are provider-centric, clinician-focused, and member-driven in our approach. I'd like to talk to you today about virtual care solutions, which is our digital technology solutions called ontobetterhealth.com. And this is a fully packaged virtual care solution. The users can go in and take a SmartScreener and I'll explain about that a little later. And this tool will then allow them to get a personalized plan that includes educational resources, access to our digital CBT modules, and that they get a triage level of assessment as well. Users can also choose additional features online to make it a more robust experience, including speaking to a live chat clinician. Also, if needed, there could be a provider search to link the individual to a telehealth screener or evaluation. The important part of this is that we know with screening populations, about 8 to 10% of those individuals will screen high risk. And it is our belief that those individuals should not be left in cyberspace on their own. So we developed an option for high risk individuals to be sent to our case management team, who reach out and triage and help that individual. So I'd like to speak to you about our SmartScreener. And this is something that we're very excited about. What we found was that there was often a delay between the onset of symptoms and when an individual was looking and seeking treatment. In response to this, Magellan developed our SmartScreener capabilities. And this can quickly access an individual's symptoms and guide them in the right resources. The software is considered quote unquote smart because it uses an algorithm to screen individuals. And what we do is we start with a short version of a scale, for example, the PHQ-2 for depression. And then the SmartScreener will skip to the next set of questions if there are no indications of that condition. If the user does yield a positive indication for the condition, then the technology moves to the next questions all the way up to the PHQ-9. Our SmartScreener has 6 validated behavioral health measure tools that mirror the modules. So we offer a depression screener with PHQ-2 and PHQ-9, anxiety with G87, insomnia with the ISI, substance use with audit and DAST, and PEG use for pain. That's kind of why we call it a SmartScreener, because it optimizes the user experience. And the SmartScreener can be as short as 9 questions for an individual with no symptoms, and as long as 43 questions for the sickest individuals. Once a user goes through the SmartScreener, they come to this page. It's called My Plan page. And essentially what it will help them do is look to see what the next steps are. And from this point, the user can go to recommended DCBT programs, a resource library, or they can download the mobile app from Apple or an Android device at no cost. This is an overview of our digital cognitive behavioral therapy program suite. Many people are familiar with CBT, but why of background, CBT therapy is actually a short-term goal-oriented methodology that many behavioral health clinicians use to help individuals reduce negative thoughts and behaviors and build new skills. CBT is considered the first-line treatment for depression and anxiety, but it's also highly effective in other conditions like substance abuse and insomnia. Magellan offers 6 modules targeting depression, anxiety, OCD, substance use disorder, insomnia, and chronic pain. And we offer a full suite as many of these conditions are highly comorbid with one another. As an example, depression can be comorbid with substance use disorders or chronic pain. And so by offering a full suite of modules, it really allows for a more holistic approach to the member's care. We use CBT modules as an intervention for members with low to moderate risk behavioral health conditions and consider the modules not only to be an intervention, but an important bridge for those individuals who are wanting to see an outpatient provider and have to wait several weeks to get that appointment. This will actually help the member start with an evidence-based care option immediately. And the other benefits are that it can be done in the privacy of a member's home, thereby reducing the stigma associated with mental health care. It's particularly useful for seniors that have mobility issues or transportation issues to access an evidence-based intervention. So just wanted to tell you a little bit more about DCBT, its impacts and efficacy. Magellan's fortunate to be one of the only MBHOs to offer a full suite of online cognitive behavioral therapy modules. The modules have been highly studied and tested in 24 different randomized control trials with more than 1,000 participants. The research has yielded good results. The modules have been shown to be effective in improving clinical symptoms and shown to be effective as medication or face-to-face visits for certain conditions. Our modules have also been reviewed by SAMHSA and the NIH, as well as American Academy of Sleep Medicine, and recognized for excellence in care. Just some statistics to highlight on these. Those engaged in depression modules on average experience a 52% reduction in clinical symptoms as measured by the PHQ-9. Those with anxiety experience on average 63% reduction in symptoms as measured in the GAD-7. So these are very effective tools and very useful as well. Next, we wanted to give you a little bit of an overview of what we did in response to COVID-19. We quickly got our IT folks and our clinical folks together to be able to offer Restore to the general public. And Restore is our module that has to do with sleep issues and insomnia. And it was found to be very effective previously for insomnia, so we thought this would be a good way to try to help people in this time of need. And as of 5/18/20, we had 318 unique users who self-registered for the program, and 137 of them completed at least one session. We also want to highlight that we are going to be working on an expansion into pediatric and adolescents. Right now, we are trying to get our next app ready to go, or our digital CBT module ready to go. We're also working on a couple of other solutions. But currently, the SmartScreener can be used to identify anxiety, depression, and trauma among the pediatric and adolescent population. And the digital CBT modules for pediatric adolescent anxiety with the companion caregiver program can be accessed 24/7. We've also done a lot of virtual programs, and this is an example of supporting youth via tech. And we had a My Life Empowerment program, and this one was in May, but the next one actually is this week, I believe it's tomorrow. And what we have done is really leveraging tech to help those youth that are stuck at home and really are probably going stir crazy. But it is no cost weekly event. We've got national and international recognized speakers and feature youth leaders and activists. That is the end of my presentation. What I'd like to do now is hand it over to Dr. Cecilia Leafsey from Penn Medicine to give us her presentation. Thank you.
Thanks very much. Let me just share my screen here. Great. So I'm a psychiatrist at Penn, and I run our integrated mental health services. I've had the pleasure of partnering with Dr. Kalega and Independence Blue Cross on our collaborative care program. But today I really want to talk about integrated care across the care continuum. There we go. First, when you look at the data at Penn, you see a striking story. 30% of our 2 million patients have behavioral health comorbidities, and these patients have high utilization and poor clinical outcomes. They increase provider burnout and total cost of care. And we, like everyone, are grappling with a broken system. Most mental illness is treatable, and yet these patients go undiagnosed for an average of a decade and die 10 to 25 years younger, often from physical comorbidities. As Dr. Kalega was saying, access to care is poor, quality is variable, stigma is high, and reimbursement is typically low. And this is a population whose motivation and decision-making are often compromised by their illness, and yet we're asking them to navigate an increasingly challenging healthcare landscape. And now with the twin tragedies of COVID and the aftermath of George Floyd, I think the stakes couldn't be higher. The good news is that the landscape is shifting somewhat. We're able to leverage data to identify people earlier. The culture is more accepting of behavioral health needs. And as we saw from Independence's data, millennials are seeking care at record numbers. We also have new ways of reimbursing for mental health, such as the collaborative care codes. So to take advantage of these new opportunities, we needed to move from reactive to proactive engagement with novel data sources, from siloed to integrated care delivery with evidence-based treatments, and from sporadic to continuous support for these chronic illnesses. And we also needed robust informatics, virtual and self-directed care, and an administrative infrastructure. So we've started several integrated programs at Penn, and the first is MEND, which will be my focus. MEND stands for Mental Health Engagement, Navigation, and Delivery, and it's a proactive mental health team that's embedded in Penn's hospitals on their general medicine floors. We started MEND knowing three things. First, mental health care in the hospital was limited. In the year prior to MEND, we only saw 1,000 psychiatry consults, but we calculated that there should have been at least 10,000. Second, patients with mental health diagnoses were staying 22% longer, which is an extra 30 hours. And third, these patients were not just being held there longer, they were literally being held there. Our patients spent more than 500,000 hours in restraints. And we discovered that this problem struck at the heart of our providers. 98% felt that their ability to provide care was compromised by patients with mental health comorbidities. They wanted to help, but felt the system was broken. So we started with step one, reactive to proactive engagement. We wanted to identify patients with mental health needs the instant they hit the hospital. So our first innovation was a machine learning algorithm. We knew that discrete data fields, such as previous diagnoses or medications given in the hospital, gave us more noise than signal. So we thought, wouldn't it be great to bring forward the words that providers use and use those? So we tried a few models, a linear regression model, which has more transparency but poorer fit, complex models like neural networks, which had a better fit but had a risk for overlearning, and eventually settled on a naive Bayes model. For the learning signal, we reviewed patient charts, identified those in need of mental health care, and trained our algorithm to be about 83% accurate. But the coolest part of the algorithm is that it's based on over 2,000 statistically significant buzzwords that we found. Some of these are expected, like depressive and suicide, but others were really unexpected, like victims or non-compliance or consequences. So step two was really moving from siloed to integrated care delivery. Our hypothesis was that by embedding a full-time nurse practitioner, a full-time social worker, but just part of a psychiatrist, we could address patient provider needs more comprehensively and at less cost. Each morning, the MEND team uses a dashboard prioritized by this MEND algorithm risk score and triages patients to the most appropriate provider. While rounding with the medical teams, MEND offers guidance, and for patients, MEND delivers evidence-based treatments and helps them see and overcome their barriers to care. The navigation component starts on day one, planning discharge based on key variables, and also working with community organizations. We also started a bridge clinic or urgent care psychiatry to make transitions in care even faster and more secure. And we try to send patients back to their PCPs and enroll them in Penn Integrated Care or PIC. So the results of our initial pilot, we went from identifying 6% of patients as needing mental health care to 44%. And instead of identifying patients on day 5 as we had previously, we saw them on day 1. We treated 4 times as many patients, and we saw that everyone was performing at the top of their licensure. And we were fascinated to find that only 1 in 4 to 5 cases required our MEND psychiatrist. For patients, the results have been meaningful. We've reduced the hours of restraint use. There are also fewer safety events. And importantly, we've seen a culture change. Providers are more aware of their patients' mental health needs and call MEND life-changing. But we needed to know that the solution could be sustainable. We were cautiously optimistic when we saw our overall length of stay decrease by close to a day, and our most vulnerable patients, our community and our Medicaid patients, had an even greater reduction. Even patients with no mental health needs left the hospital sooner, and we called that our MEND halo effect. So the future of MEND that we're planning now is algorithmic mapping of the whole hospital with the ability to smart room patients, more support for high-risk populations like new moms and elderly patients who become delirious after surgery, and rapid response behavioral teams to help with agitated patients and ensure staff safety, and a seamless extension to outpatient care, home care, and virtual care. So moving to outpatient, I'll give you a very quick overview of Penn Integrated Care, which, as Dr. Kallega said, is based on the collaborative care model in primary care, a model which has been around for 15 years with over 80 randomized controlled trials showing efficacy. We identify patients through screening, through the primary care's clinical judgment, or through proactive reports that look at high-risk comorbidities like heart disease and depression, or lung disease and anxiety. The primary care doctor remains the point person on the team, and there's an embedded licensed clinical social worker who supports this provider by delivering behavioral interventions in the practice. And the consulting psychiatrist works with the licensed clinical social worker and with the primary care doctor on treatment plans and medication adjustments. To navigate patients to the right side of care, we have a virtual resource center staffed by care coordinators who use decision support software to assess, triage, and refer patients either back to integrated care to be treated or to specialty care in the community. Our demand for the program has been explosive. 15,000 out of the 100,000 patients in the practices we're in were referred, 10,000 were enrolled and triaged to care, and 5,000 appropriately scheduled for collaborative care back in the practice. We also caught 1,500 patients who were actively suicidal and may have otherwise fallen through the cracks. Our depression and anxiety remission scores rival controlled research studies at close to 50%, and we're beginning to see benefits on the physical health side with better control of diabetes and hypertension. And we're doing this with 10 times less psychiatry time than we use in our typical outpatient psychiatry services. And Independence is doing a matched analysis of total cost of care, and our preliminary findings are quite positive. And like men, providers simply love this program. So this is a really busy slide here, but what we see here is the whole continuum of integrated care. And what we're really working on now is how to support it with both community engagement, which we're calling MendX, and a virtual platform called Cobalt, which we built for our frontline healthcare workers to specifically target COVID-19 related mental health issues about 6 weeks ago. Cobalt's a virtual platform that uses algorithms to curate content and to triage our employees to individual and group sessions. Cobalt really has 3 buckets of resources: one-to-one support with peers, resilience coaches, psychotherapists, and psychiatrists; group support that ranges from mindfulness to trauma groups to substance use groups, and also self-directed content like online CBT modules. And in the first 30 days, there was an immediate demand from our frontline employees with over 5,000 users. Interestingly, 50% of them logged in anonymously, over 10,000 sessions and 50,000 page views, and a number you can't really put a value on, 50 employees who were suicidal and connected to care immediately. As a seasoned emergency room doctor said to me, she said, in my 30 years, I've never experienced even close to this type of stress, horror, uncertainty, fear, and anger. And I think that's true for everyone, but especially right now for our Black colleagues and patients and community, and all of us who are grappling with a different kind of pandemic as well. So we see these programs, all of these integrated care programs, as a way to help people tolerate hard things, not get rid of them. And through care across the continuum, we want to build resilience and treat symptoms and teach self-care. And our goal for all of this is really to give our employees and our patients the space and the tools to be comfortably human. And now I'm really pleased to announce Matt Miklett, the Senior Manager of Clinical Operations for NeuroFlow.
Great, thank you guys so much. If this doesn't pump you up, all this cool technology that's coming out and what's becoming available to our patients, I don't know what will, because this is better than my cup of coffee to get me going today. But as Cecilia mentioned, I'm Matt Miklett. I'm the head of clinical operations for NeuroFlow. By way of background, I come from a military clinical setting where I treated combat trauma and also led an inpatient psych unit. So did a lot with restraint use. So incredible to see how technology is now being incorporated for these ways that we used to have to think about patient education and using policy. So the ways we're using technology now are just so incredible. So more recently for me, I've been working in mental health and substance use policy. And when I think about the problem that we're addressing today, I think most of us are pretty familiar with the behavioral health capacity issues that we face. And if not, we certainly have touched on it a bunch already this morning. The problem is that this problem is only getting worse. And even before COVID and the unrest that we face today, we knew that we could not train and hire our way out of this problem that we're facing. We need technology. We need it for prevention to slow the flow. We need earlier identification of at-risk individuals. And we need to enable care teams to more effectively deliver these evidence-based treatment models, such as collaborative care at scale. One effective approach is using stepped care. It's a way to make sure that we're getting the right patients to that right level of care. But providers often feel largely unprepared, and even if there are protocols in place, clinical workflows often don't support them, and there's often inconsistent screening and the measurements and data we need to then effectively utilize those workflows. So we help providers with that in three main ways. The first thing we're doing at NeuroFlow is to help with measurement. So we touched a bit on some of the screeners that are used. So validated assessments such as PHQ-9 or GAD for anxiety, depression. We have a host of 20 more that are involved in our platform. We also use subjective data. So you can think about things like pain, mood, sleep, and also incorporating more and more biometrics. So thinking about things like activity data. How much is somebody getting up and actually moving? But we also know that more data is not necessarily helpful for providers. When you only have 15 minutes for a visit, you don't have time to digest all this new information. So the next thing we're doing is really helping to manage, help providers make sense of that data, provide some clinical decision support to help them understand what is the next step I should be taking with my patient, making that physical health provider who never felt comfortable treating mental health feel more empowered to take care of that patient and that whole patient. And the third thing we do is motivate. There are some incredible evidence-based treatments out there, digital cognitive behavioral therapy being one of them, but without patient adherence, you're not going to see the improved outcomes. We need patients to engage with that care and want to be involved. Our patient has two platforms. Our platform has two sides, sorry. We have a care management side, which we call our care team dashboard, and a patient-facing app. And it's also available as a web version for somebody without a smartphone or a tablet. Organizations determine what their own goals are. We work with them to determine what do they want to assess and look for. These outcomes then feed back into the care team dashboard and even help to auto-deliver individualized content back to that patient based on their outcomes. So if I screen positively for anxiety, I'm going to be getting anxiety-related content. Whereas somebody else who maybe screens positive for depression or doesn't screen for anything at all will either get depression content or maybe something more like resiliency or positive psychology. We also have EHR integrations. So medical providers don't have to access our native dashboard, and instead all that discrete data and that clinical support can then feed right into that EHR where they're already utilizing. This is a real quick look at the patient-facing app. The first thing I would hope that you noticed is it doesn't look clinical. So while you need a provider or some organization tied to the platform, we built it very much with a consumer mindset. All of our engineers have came from the consumer world to make this look and feel like something that you actually want to engage with. We use behavioral economic approaches, including rewards programs. And with these strategies, we have incredibly high engagement rates. So we have 76% of our patients are staying on the platform after 6 weeks. The care team dashboard includes a number of different permission levels. What that allows for is for hospital and organizational leadership and population health leaders to view just that enterprise high-level data to better understand what's going on at their whole patient population. All of our content is also customizable. So our strategy is not to throw the kitchen sink at everybody. We want to make sure that we're using the right messaging and providing very specific organization resources to make sure that patients are not confused and just getting a bunch of information thrown at them, but feel like it's tailored to them and getting the resources that they can best utilize. We also have care team alerts to help our care teams respond in mental health crises, or to provide resources to those patients that are otherwise at risk. And our clinical decision support allows us to incorporate treatment algorithms or care pathways into the workflow to help providers understand, what do I do next with this patient based on past assessments and the current treatments that we're doing. Our ultimate goal is to help organizations incorporate behavioral health into practice. No matter where the organization is, we come in and help support and scale that effort. So it could be something as simple as coming in and doing in-clinic tablet screening, all the way to serving as that functional registry needed for collaborative care. And what's great about having a cloud-based registry now is when you need a psychiatrist or somebody else on staff, we can now have that person be remote because we have a cloud-based registry where we can now bring that person in and help support those clinics. We're supporting organizations across the country, including, we really work with three main populations. The first being our home, was with behavioral health specialists. We were originally designed as a tool for therapists to deliver homework assignments and be able to practice measurement-based care. But I've now moved on also to physical health settings. And we're in a number of different settings, from pain clinics. We have a specific OBGYN platform where we address postpartum depression. And we also serve population health organizations. So you think about, we're working with insurers and employers. We also have a big footprint in the military and first responder community as well. And while we know that certainly the treatments are again, the same, and there are very effective treatments that we can use, if the messaging isn't right and you don't make it feel like it's for them, they're not going to engage with it. So understanding that when it comes to military and first responders, it's much more about using language around human performance, right? And understanding security concerns and addressing those concerns that each individual population has. That's why we take the approach of working with organizations to collaborate to make an effective program for them. As for our outcomes, I want to be really clear here that our goal is to empower providers. So while we're seeing incredibly awesome numbers coming our way, we think that the numbers we're seeing here are because we're empowering the patients and the providers with NeuroFlow. It's led to patients being more engaged. I mentioned earlier that 76% are completing activities past 6 weeks. The industry standard is 10% with digital behavioral health. They're also completing 31 activities on average the first month. That means they're coming in, watching videos, tracking their mood, tracking their sleep. We're improving patient outcomes. And this is done by supporting these existing evidence-based delivery models, helping providers that never thought about measurement-based care start tracking those outcomes with their patients that are coming in month over month. And we're also providing a new revenue stream for clinics. With these new codes that came out, particularly collaborative care codes in 2018, we're offering new ways to not just incorporate behavioral health into practice, but to make it a new opportunity for that clinic, particularly during times of COVID when we need more remote options. So I really appreciate the time today. As I said, this stuff gets me super excited, so I'm really excited to have this invite. There are two websites here just for some free resources that certainly we've put out related to COVID-19 and provider burnout. And certainly provider burnout is an area where we're hoping to be able to help and support moving forward. But I'll leave it there, and Ginny, I'll kick it back over to you.
Thank you so much, and thank you to all of our presenters for a really fascinating conversation addressing issues around access and how we can improve access, issues around quality of care and how to improve quality of care for our patients, but also for the providers delivering that care, and then how technology can support the clinical models that are out there in the community. So to our panelists, as we think about the populations that we serve or that we're trying to reach, are there particular populations right now, while we're in the middle of a pandemic and in the middle of an enormous emotional outpouring over the great loss of Mr. Floyd, are there populations we should be focusing our attention on right now when it comes to behavioral health? And are there some populations more at risk than others? So I'll open it up to the panelists.
Hi, Jenny. I'm happy to talk a little bit. I think there are a lot of different populations, but certainly my experience right now is with the healthcare workforce and also the Philadelphia community. And I will say that it's been interesting watching from kind of a psychological community perspective, the different stages. So typically there's sort of a heroic stage at the beginning of a disaster where everyone has a lot of energy and pulls together and feels part of a team. And then there's a disillusionment phase that I think I'm seeing among healthcare workers, where there's a lot of emotional exhaustion and trauma symptoms coming out right now. And I think the way to support people is really focusing on both treatment, but also community and self-care and connection, because a lot of people are feeling very isolated and alone, even if they're in a hospital working with other people.
Other thoughts about that? Are there other populations we should be focused on?
Yeah, absolutely. And for me, the first thing that comes to mind is the rise in domestic violence and child abuse that we're almost certain to see during this time. So making sure that organizations are thinking about how do we help report that? How do we help people feel empowered to report child abuse in their own settings? Another really important tip that I would like to pass along is to make sure that you're checking in on your staff members, and not just through text or email. Really what's been shown to work most effectively is to do it by voice. So whether that's Zoom like we are now or a phone call, to make sure that you're checking in at least once a week with each member of your team. And finally, as far as populations go, we're certainly working with first responder and military community who first responders now we know are facing a lot. They have additional stressors, not just of working long hours now, but are often seen as the enemy. And when you are maybe potentially identified as a change maker in those organizations, that can be incredibly deflating and demoralizing. So how do we help and at least give them the resources and tools so that those change makers that are in those organizations can continue to do the work that they are to change these organizations to make them better for our whole community? That's a lot of what our goal is here, is to support those communities.
So, yes, Varun?
No, I was just going to actually point out also that in the recent years, we have had a significant uptick in suicide in general, to the point where it is now at an epidemic level. And healthcare workers in general are at a much higher rate of risk than the general population is. So looking at not only our frontline workers, but our healthcare professionals in general, to make sure that they've got the resources that they need, that they've got the voice they need in order to really combat some of the significantly high burnout rates that we've had. I think on average, we lose a physician a day to suicide.
Wow, that's a really sobering statistic. Wow. So as you think about these populations that you've all mentioned, all of which are critically important, at a time where we're not able to physically get together, how can we use technology to connect with each other, to help people practice? I think, Cecilia, you talked about self-care. What can we do, or what types of tools and technology are out there that we can share so that people can reach out and connect and get the help that they need?
So I can certainly talk about what we do here at NeuroFlow. I think it's all about culture in a workplace, and we have our weekly happy hours where we're getting together on Zoom and often playing some sort of games. So we use a lot of Jackbox games. I'm not getting any money from them from dropping their name, but just finding ways to get together and normalize the relationships again, right? And it felt very forced over Zoom originally, but the more we get together and the more we kind of try to play games and speak with each other, the more those walls have felt like they've broken down, and we're able to kind of feel a little bit of sense of normalcy, at least for that short period of time.
In Varun, you had, I'm sorry, go ahead, Cecilia.
Oh, I was just going to say, speaking from sort of a clinical perspective, we've had to really transform the way we deliver care and use telehealth, a lot more widely. And I think that's probably one of the silver linings of COVID, is the expansion and the decrease in restrictions. But with the caveat that some of our community, has a difficult time with Wi-Fi access, with their data plans, or not having phones at all. And so really trying to think creatively about how we can make sure that everyone can stay connected, supplying people with phones, thinking of, free Wi-Fi, things like that. And I think in whatever organization you're in, really understanding the different burdens that different individuals have, whether that's, technology issues or childcare issues or other things. I think everyone is sort of going through this a little bit differently, and understanding that variety is important.
Varun, I was going to ask you, you highlighted a lot of free webinars and resources that Magellan has on a weekly basis. How do you get the word out that they're available and that people can access those resources?
We've got a whole external communications team that really emphasizes that particular point. They really try to get that word out and make sure that everyone knows what resources there are. And Magellan has been actively putting together things on a weekly basis, whether it be webinars or Q&A type things, or any kind of resource guide for individuals that need it. Most of it is posted on the website, but our marketing team has also been going out and letting the larger organizations, national organizations, know that we've got these resources, and we're willing to be there and willing to help.
Great, thank you. We have a question in the chat around technology. So you've all described technology tools that you all are using to help deliver care, improve access, improve the quality of care and the outcomes. From each of your perspectives, are there gaps in the technology? If you were king or queen of the world, what additional technologies would you want to be able to deploy to help further the care of the patients that you work with?
I think we've mentioned the fact that we need universal broadband. So having cloud-based cities where you've got broadband for everybody, if we could have that on a national scale where nobody has any kind of limitations in the sense of being in a rural area where there is no broadband at all, that'd be wonderful, because then we can really tailor a lot of these digital solutions to specific populations, knowing that everybody can access whatever we've put out there.
Yeah, for me, it's always about connecting the dots, right? It's about connecting these systems together in a way where everyone understands what's going on and gets that full picture. So let me give you a quick example. The Department of Veteran Affairs has put out so many fabulous mobile apps. They're based on evidence, they work, they've been studied, but none of that feeds back to a care team. So it just lives in silo. And additionally, if I have more than one condition, now all of a sudden I need more than one app. So, you know, what I would like to see is that we use this tech that already exists, where we can have patients feeding information to the providers then able back to feed it to the patients, where it's feeding into the EHR, where that's then being pulled into the HIE, right? Where we're using that now, being able to pull that into big data and be able to use that information, not just for that patient insight, but now we're using that much larger power in order to gain population health insights. So to me, it's the power and the engines there. We just haven't connected the dots in a way where it's been most effective.
And I would say that the patients that really keep me up at night are the ones that fall off the grid. And so for me, it's that ability to monitor patients, whether that's digital phenotyping in order to see when people, you know, stop using social media as much or post certain things, or whether that's biomarkers or genetics, or feeding, kind of what Matt was saying, but from more of a proactive approach of connecting all the dots early on to really see when someone's starting to struggle, so you can intervene early. Because often by the time you know, someone is in crisis, they've, you know, dropped off their apps and their care, and they've disconnected. And so that I think is an area where technology can really improve things.
Thank you for that. And you all are king and queens for the day, so you do get your wishes for today, hopefully. Cecilia, just to build off of what you were just talking about in terms of connecting the dots, we have a question around the data that you get every morning to triage patients. And the question is around, is that for existing patients or just new patients? And how, what additional information is changing for existing patients?
That's a great question. So every day it's for every patient, new and existing, and it's really using that natural language processing, looking at all of the text in the notes. And this is what I was talking about earlier. is the discrete data really didn't give us a lot of signal, and we really had to go to the notes themselves to find these words that indicated that someone was struggling. And so we're running that algorithm and also feeding back into that algorithm so that it learns sort of every day. And if we see that an existing patient has a new concern or a flag that comes up, then we go and see that existing patient. If it's a new patient, then we do the same thing.
That's great. Thank you so much for that. So as we think, you know, as I usually say, in the time of COVID, there's been a lot of dramatic changes, right? So we're all getting used to using video conferencing, be it Zoom, Skype, whatever. We're used to interacting with patients, and as a clinician, diagnosing patients. You know, I've heard some great stories of diagnosing people's appendicitis via telemedicine. What do you think telemedicine will look like post-pandemic, or what do you wish that telemedicine would look like post-pandemic, right? So we've had, you know, broadening of access, we've had increased use. I mean, for independents, we've seen a 3,000% increase in the use of behavioral health telemedicine just in the last, 60 days or so. So what do you know, and we've also seen relaxation of what were sometimes very restrictive requirements around the types of telemedicine platforms that can be used, right? So now it's acceptable to just use your phone to FaceTime your doctor. Post-pandemic, what do you see that looking like, or what would you wish that to look like?
Ginny, I would look like it does now, where they make it permanent. The restrictions are gone. The regulations that have been barriers will be gone. I've been practicing telepsychiatry since 2006, and I've seen the industry grow and explode. But the hindrance of full growth and mainstream acceptance was always all of the requirements, restrictions, and regulations around it. Now that that's relaxed, I think that's the reason why you're seeing such a huge interest in telehealth and mainstream acceptance of it.
Thank you. Go ahead,
okay.
Cecilia.
I was just going to say, for me, I think it's, I completely agree. And I think it's really about patient preference. I mean, I want those people who feel comfortable using telehealth and enjoy it to use it. If someone wants to come in and see me, I want them to be able to do that as well. And it's not always the people you suspect. Just last week, I had a patient who had missed the last 6 appointments and had housing insecurity and has schizophrenia. And I called him up on FaceTime, and he was like, "Hey doc, haven't talked to you in a while." And we had our appointment, and I was like, wow, this is terrific.
Yeah, and I would just add, I think there's a lot of great advances in things like e-visits, where, very routine visits that maybe I don't need to go to the office for. I know what a UTI feels like. Can you just call that into my pharmacy? And remote patient monitoring as well. So the more we can be able to track patients over time and be able to identify these symptoms or deterioration of symptoms earlier, the better it'll be for everybody. So how do we incentivize more of that? And I think value-based care is certainly one way to do that. But the more we're monitoring those patients over time and earlier identification, it'll only help everybody.
Great, oh, go ahead.
No, I was just saying I completely agree.
Great, thank you. So I think we touched on this a little bit earlier, and I think, Cecilia, you went very nicely through the various stages that we're going through from the impact of COVID. We've now had another, massive impact from the activities recently that's, impacting our nation's psyche, and how we're responding. How do we help our communities, right? So how do we help our patients, but how do we help our communities to heal from this double impact that we're having right now, we're living through right now?
To me, it's listening. You know, I was always told growing up, you have two ears and one mouth for a reason, right? So I think we all need to do a better job listening and hearing each other, understanding what a struggle means to different people. That's what I'm trying to do. That's my goal.
I think as a nation, we need to really understand how big of an impact this has been for the minority communities. I mean, first you had COVID, which was really decimating those minority communities. And then on top of that, you have this event. So part of it is we really have to get to a point where we can truly empathize with what's going on with them. We can't live the way they've lived. We haven't been in their shoes, but let's try to put ourselves in their position and try to understand the world that they live in order to help equalize the situation. If you look at healthcare inequities, social determinants of health, oftentimes mostly affect more the minority communities than it does the general population. So how do we incorporate social determinants of health into everything that we do in healthcare? Those are going to be the first steps, because in order to really help them generally with healthcare, with everything else, we've got to take into consideration all of those social determinants that play such a huge role, and that we're not going to be able to make any meaningful shifts in healthcare data unless we're addressing the whole big picture.
Yeah, to me, also, I agree with both of them, and also think it's really important to be able to acknowledge and hold the emotions, the anger, the frustration, the uncertainty and fear that everyone's feeling from COVID, from the civil unrest, from, you know, a lot of from job losses that are going on in the country, and not to say that, you know, we need to sweep these things under the rug or that we shouldn't be feeling these things, but really, you know, as Matt said, listen to people, acknowledge what they're feeling, and tolerate the emotions.
Great, thank you so much. Looks like we have a couple questions in the Q&A section. I'll see if we can address some of them in our remaining couple minutes. There's a question, you know, thanking the panelists for a wonderful discussion, asking what treatments besides getting proper medication are available there? Are there alternative ways, meditations, physical activities? So any suggestions from our panelists?
Yeah, I would say a huge range of things you can do, from medication to psychotherapy to physical activity has been shown again and again to have a huge impact on mental health. Things like meditation, things like you know, group work and social connections, and self-care. There's a whole range, and that's why I think all of these different kind of interventions and platforms and technologies and human components all kind of work together to help people. I think thinking of mental health a little bit like physical health, where, you know, even if you're completely healthy, it's good to go for a run every day. Even if you feel really well, it's important to be building resilience and to be taking care of your mental health as well.
Great,
I'm
thank
going to
you.
just wrap up here. I really want to thank all of our speakers and panelists, Ginny, Varun, Cecilia, and Matt, for taking the time this morning to share your expertise and wisdom around behavioral health, mental health. As I said on the outset, it is with heavy heart that we deliver this program, but recognizing the importance of behavioral health, I would encourage all participating, recognize and reach out for yourself to resources, to your friends, to your family for resources. We've recorded this session. We'll share that. We will share the slides and follow up with the Q&A. Again, I want to thank Independence Blue Cross and Capgemini for their support of this important topic and effort, and also encourage all participants to look out for our survey on this program to help us optimize and improve for future programs and our upcoming events. At PACT, as I said, We thought long and hard about canceling and rescheduling this. Given the topic, we thought it was important to share, but we are pausing additional PACT messages and any business as usual in observance of Blackout Tuesday for the rest of today. I wish you all a good day, encourage you to vote, and again, once again, thank everybody for your participation.
Thank you.